Can I have the slides, please? Yeah. So I am Dr. Rishi Swarup. I am from Hyderabad, and my co-instructors, Dr. Fogla couldn't make it. Dr. Sama Basak will be filling in for him. He's from Hyderabad. Dr. Sama Basak is from Calcutta. Dr. Ashish Nagpal from Ahmedabad, and Dr. Siddharthan. We also have Dr. Christopher Liu, who will be giving us the keynote address from UK. Like I said, we'll start with an overview of DMEK and then some points about donor preparation and insertion, followed by a talk on how to unfold and ensuring it's the right way up, some complications, some simple ones and some dreadful ones, and then some tough situations from the expert. Then we'll have the keynote address followed by a panel discussion. So endothelial keratoplasty has been evolving. It's gone through PLK, DLEK, DSEK, DSAEK, DMEK and PDEK are now what people are doing. We'll be talking about DMEK in this particular course. So what are the reasons why one shouldn't be doing DMEK? It's a difficult surgery. Is there a pointer? It's difficult to learn, and it takes longer time, especially in the initial stages. So if you're a person whose surgical time is of paramount importance and you need to finish in a hurry, you'll always try to defer doing a DMEK. If you have an option to do a DSEK, you'll try to do DSEK. So that's what happens to all surgeons who move from DSEK to DMEK. DSEK is so quick, and once you've gone through the learning curve, it really doesn't take more than 10 minutes. So DMEK does take time, especially if you have a little bit of a problem. Then in a country like India, we always have a paucity of good quality donor tissue, and that's always a challenge, especially if you're not in an institution which has an eye bank attached to it, so you don't have a backup tissue, so you have all those issues. One funny thing about DMEK is you can't use the best tissues for DMEK. The ones which are really young are little difficult to use unless you're a very experienced surgeon. Especially for the novice surgeon, it's not recommended to use a tissue that's less than 45 years. So the ones that have the best counts are funnily contraindicated for DMEK. And then you have, because it's a difficult procedure with higher complication rate, sometimes you need to do repeat procedures, especially rebubbling is very common. And sometimes in private practice especially, it's difficult to explain to the patient you need to go into the OR once more, because the patients are very demanding, and so we tend to kind of avoid doing a procedure where you need to do another procedure. The counterpoint is you can actually tell the patient that it's a two-step procedure, and that way the patients are quite okay with it if you tell them in advance. And of course the complications, they are feared. I think all corneal surgeons would agree that this is one of the difficult surgeries. Manual DALC was one surgery that needed a lot of skill, and maybe this is the other one. So that's another thing why people tend not to do DMEK. There have been some publications showing the learning curve, and generally the learning curve may take up to about 50 cases for a skilled surgeon, and for a non-skilled surgeon, of course, it's going to be a lot more. And during the learning curve, you can have up to 8% tissue loss, 20% primary graft failure, and almost 92% rebubbling rate, which is like a very, very high rate. So that's about why you shouldn't be doing DMEK, but why should you be doing DMEK? I think the very compelling reason to be doing DMEK is because the graft rejection is much, much lower, almost 1/5 that of DSEK. It's faster and has a slightly better visual recovery than DSEK. And with time, we have understood how to do the procedure better. There have been some surgical nuances have been understood. We've learned how to tap and unfold the tissue better. So with all those things, the surgery has become a little more repeatable and predictable, and thereby the outcomes have started getting much, much better. So these are the reasons why one should start doing DMEK. It's important to select the patients carefully. Your donor also has to be selected carefully. Avoid too young donors, like I told you, they sometimes tend to have a very tight scroll, which may not open up easily sometimes. The descemet membrane may be adherent and may not peel off so easily. Diabetics, they tend to have more of tears of the descemet membrane. So if possible, avoid a diabetic donor. Avoid donors in which the fellow eye DMEK harvesting has had difficulties. Both eyes tend to behave in a similar way. And generally you want at least a 2,500 count when you're taking a patient for a donor tissue for DMEK. Even selection of the patient is important, especially for the novice surgeon. One of the things that is necessary, especially in Asian eyes, where the iris is quite pigmented, is good visibility. So if you have a stromal scarring or a haze, and you may not be able to see the DM scroll so well, then such cases are not ideal for the beginning. You must have an intact iris and pupil, otherwise your graft can get stuck to the iris, or it can hide behind a large pupil, or the A bubble may not stay in place to keep the DMEK graft in place. So all those things will cause problems. There should be no vitreous in the anterior chamber or synechia ideally, because again these are places where the scroll can go and get adhered. If you have too deep an anterior chamber, it's difficult to give good unfolding of the graft, and also to give good tamponade. Avoid aphakic eyes for similar reason, and again post-filtering eyes, because you don't get a good unfolding of the graft in these cases, and the eye is generally soft. Unlike other lamellar procedures for DMEK, you do need some specific instruments which make the surgery much more predictable and easier. You have ready-made sets that are available from some companies like Goider and Doc, and even some Indian companies have got very cheap sets that are available. You have specific instruments for the recipient for all steps, right from stripping of the descemes membrane to insertion of the scroll into the eye, to cannulas for opening up the scroll, to cannulas for inflating the anterior chamber with both balanced salt solution and air. So you do need a specific set of instruments for DMEK, not just for the recipient but also for the donor. Again, for donor you have instruments to strip the descemes without causing trauma. You have instruments for marking the anterior surface of the descemes membrane so that you can be sure of the orientation. It's a good idea to use a guarded trephine which will only cut the descemes membrane and not the stroma. And of course, a variety of inserters are available for DMEK made of glass, and also nowadays we have IOL cartridges being used. So we'll just cover some of that as well. So when one is getting started on DMEK, it's important to go for wet lab. You may be able to do many corneal surgeries without really doing a wet lab practice, but this is one surgery which you cannot do without a wet lab practice. So practice, 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 both the recipient steps as well as the donor steps. Important to observe videos and live surgery both online and see an experienced surgeon operating DMEK. Ideally, you should see some complications being managed. And initial few surgeries, it's always a good idea if it can be supervised. Go for the simplest cases first, like fuchs, clear stroma, intact pupil, AC not too deep, and then you can get started. So that's just a quick introduction, and then I'll just give an overview of the DMEK procedure. I'm going to the next talk. Sorry. So I'll just run through the surgeries. The donor preparation, this is partly covering my second talk as well. So basically you need some sort of a Teflon block on which you can keep the corneosteral rim. Initially it's a good idea to mark the limbus so that when you invert the graft you know the borders of the limbus. Then you invert the graft. It's a good idea to first make an initial trephination of a large diameter. In this case, I'm using a 10 millimeter. One could also just core the peripheral descemes membrane to cut it. The idea of this trephination is just to get a peripheral cut from where you can start stripping the descemes. So you can even use any sharp or semi-sharp instrument to just core all around and then start stripping. It's a good idea to also stain this edge so that you can actually see the cut edge of the descemes membrane, and it helps you kind of visualize the descemes membrane better. Now you can see the edge, and you can go all around and just lift that edge of the descemes membrane with any blunt instrument. In this case I'm using a Sinskey hook. You have specialized Desmes elevators that are available also if you want to spend money on those. It's a good idea to go all around and lift this Desmes up, because when you punch, that Desmes membrane gets tucked into that groove. So if you don't lift it all around, sometimes it can get stuck. Then you use a non-tooth forceps. In this case, I'm using a curved suture type, but you could use any blunt tipped instrument with ideally something which has a broad tip, so it can grasp a larger amount of Desmes membrane without traumatizing it. And you basically you do this stripping under fluid so that the surface tension is reduced, something like the scuba technique. And basically you can use 1 or 2 hands, and you have to basically strip slowly and keep an eye on this line. This should always be straight. If at some point that line is getting kinked, that means there is an adhesion between the Desmes membrane and the Duas layer, and it's at that point that it can tear. So if you ever see an adhesion, try to go around it, or maybe go from another area and come to that area in the end. Or you could use the little dissector and kind of gradually try and separate that from the other side. So you can see I'm doing this very tentatively, gradually. As I'm watching this edge, slowly strip. You shouldn't strip the whole thing. About 2/3 is what you need to strip. And once you've stripped about 2/3, you can just make it lie down, and you have to stain this part so that you can identify the stripped from the unstripped area. That's what we're going to be doing. And once you've done that, you put it back, you invert the graft, and I'm sorry, I think I skipped one video. So after you've strained the stripped area, you kind of make a punch in the area where the Desmes membrane has been stripped off. And this is a small 3 millimeters or 2 millimeters window. You can use your keratoprosthesis, Trephine, or a dermal punch to create this little circular opening. And that basically helps you to get a window to mark the anterior surface like so. So now the graft corneal button has been inverted, and that punched button has been lifted up, and you can put any asymmetric mark. You have ready-made stamps, or you can just stain a Sinskey hook with gentian violet and put the mark. So it's important to put an asymmetric mark like F, S, or a P, so that you can check the orientation when it's inside the eye. Don't put an O. Yeah. After that, you trephine to 8 mm. Ideally, again, this should not be a full thickness trephination, but a partial thickness, just to cut the Desmes membrane. And then whatever is left can be stripped off. Once that is done, you stain the scroll for about a minute or 2 with trypan blue, and under fluid you can aspirate it using one of the various injectors. So most of these DMEK injectors or cannulas have a broad end and a narrow end. So while drawing the tissue, you keep the narrow end towards the syringe and draw from the broad end. And once it's inside that injector, you can invert it and then inject with the narrow end facing into the anterior chamber. So that's what you do when you're in the recipient. You just, it's a good idea to have an inferior PI. You can do a YAG peripheral iridotomy preoperatively, or intraoperatively. You can create a small iridectomy. Then you strip the Desmes membrane. You can do it under air or under a cohesive viscoelastic like so, just like we do for DSEC. It's a good idea to mark 8 mm on the anterior surface and then do this. And then aspirate the viscoelastic. You can do this surgery through a clear incision or a scleral tunnel, whatever you prefer. And then basically you have to shoot your graft in, I'm sorry. You have to gently inject your graft in. It's important at this point when your graft has gone in that you make sure that the eye is soft. Otherwise, when you come out, the graft tends to come out. Also, you have to give some counter pressure to hold the wound as you're removing your DMEK injector. Otherwise, again, the graft can slip out. I'm sure Ashish will show us some of these complications. It's a good idea to suture these wounds, at least initially. And then, of course, you can start all your tapping maneuvers. This is the one place where DMEK is really different from DSEC. We tend to press more when we're doing DSEC, but in DMEK, this is more of a like a drumming kind of a gentle taps. And there's Techniques of tapping, I'm sure they'll be covered later, so I won't go into the details of those. And then basically you try to flatten out the entire graft like so, using various tapping and egress maneuvers. And you can see the mark there. I'm sorry, it's not so well seen on the screen. And then you inject a small air bubble and then you enlarge it. You can see the mark here now, F. So you can see the outline of the graft quite well. It's fairly well centered graft. And the beauty about DMEK is the way it clears up. Sometimes you can't even make out that a surgery has been done in many of these. So this is an important slide showing the correct orientation. Descemet membrane always tends to scroll with the endothelium out. And this is the way it should be oriented for it to be the correct way. And if it is oriented this way, that means it's the wrong way and we need to invert the graft. So results, the study, I think I'll just move on in interest of time. So important pearls, practice, again I'll say practice, 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 select your cases properly, select your donor properly, counsel the patients well, tell them it's going to take time and you may need 2 surgeries. And don't give up, keep trying till you succeed. Most successful DMEK surgeons have gone through a phase in which they started, gave up, then restarted, and then they started doing regularly.